In this second talk, we are going to look at some clinical scenarios and the related chest x-rays and talk you through some common abnormalities you may find on x-ray. So before we start, we're going to be going through several cases fairly quickly, and therefore what I would suggest you do is when we show the first clinical scenario, each clinical scenario with its x-ray, you pause the video so you can take your time to interpret it. When we get to the second slide for that case, there is a written explanation. So after you hear what I have to say, again you can pause and read it at your own pace. So again, we've looked at the systematic approach, and now we are going to apply it to some x-rays with common abnormalities. Just to remind you of the A, B, C approach. And of course, we must start with a look at a normal x-ray before we move on to anything abnormal. You may want to just pause here and just remind yourself what a normal x-ray looks like and the different measurements we spoke about and the different shapes and textures of different parts of the x-ray. So here's our first case. A 63-year-old female patient presents with a 4-week history of increasing shortness of breath on exertion. And we want to know what the x-ray shows and what are the likely causes. So pause the video, have a look, see if you can apply the ABC approach and come up with an answer. This shows a left-sided pleural effusion. You'll see that there's loss of the left costophrenic and cardiophrenic angle with a homogeneous opacity below what looks like a meniscal line. There's also some reticular shadowing throughout both lung fields. This picture may be due to malignancy, infection, or inflammation. We need to think about autoimmune diseases like rheumatoid arthritis or SLE. Bear in mind, pleural effusions can also be seen in cardiac failure, renal failure, and hepatic disease with hypoalbuminemia, but these are usually bilateral. The second case is a 23-year-old female with a 4-hour history of left-sided stabbing chest pain and shortness of breath. This is quite subtle, but can you see what this x-ray shows? And how would you manage this patient? Again, pause the video. This shows a subtle left pneumothorax. The left lung field is more loosened than the right, and there are no markings up here in the apex. Let me just put on my pointer. Yeah, so there are no lung markings up here. And actually, you can see the edge of the lung between the third and fourth ribs. It's difficult, but you can see it. If this patient is stable, then they can be managed conservatively. Here's a 50-year-old man with increasing shortness of breath and weakness. He's pale and tachypnic. What do you think this x-ray shows? Pause the video, look at the questions, see if you can answer them. So this x-ray shows a classic globular heart, which would be in keeping with pericardial effusion. The diagnosis now would really be confirmed by echocardiography. Likely causes would include inflammatory disease, renal failure, viral illnesses with pericarditis. This patient may need pericardiocentesis, but that will be done under ultrasonic or echo guidance. Here's a 53-year-old man with fever, chills, and rigors. What does this x-ray show? What's the likely organism? So again, pause the x-ray and have a proper look. This shows a right upper lobe pneumonia. This sort of lobar pneumonia is likely to be caused by strep pneumoniae in a patient of this age. In our setting, community-acquired strep pneumonia is still generally sensitive to penicillin, so this can be used. If you look at the lower border of the consolidation, it's a fairly straight line, which suggests it might be the horizontal fissure, but the horizontal fissure, as the name implies, should be horizontal. And therefore the fact that it's pulled up like this suggests there's some loss of volume in this upper lobe. So we treat this. If the patient is a high-risk patient, such as a smoker, or if this consolidation does not resolve after 6 weeks of treatment, that would be grounds for further investigating the patient to rule out a bronchogenic carcinoma or some other underlying cause for his infection. Here's a 73-year-old man with long-standing stroke who presents with fever, cough, and shortness of breath. Pause the video. Tell me what you think you're seeing. This is a consolidation of the right upper and mid zones with some sparing of the lung apex. In this sort of picture, that history of stroke should alert us to the possibility of recurrent aspiration due to poor gag reflex and inadequate airway protection. In this sort of pneumonia, you need to make sure that your antibiotic coverage includes coverage against Staph aureus and anaerobes. This is a 35-year-old clerical worker who works in an air-conditioned office and presents with a 2-day history of fever, dry cough, and shortness of breath. Again, what does the X-ray show and what's the likely diagnosis? Pause the video, have a good look at the X-ray, apply the ABCs, and see if you can come to some conclusion yourself. This X-ray shows bilateral basal reticular shadowing, and this pattern in a young, previously healthy female would suggest an atypical pneumonia. You need to think about other less common diseases such as Legionnaire's disease, and in the immunocompromised patients, such as in an HIV positive patient, other opportunistic infections such as pneumocystis PCP, pneumocystis carinii pneumonia. In this patient, you would consider starting a macrolide antibiotic. And of course, if Legionnaire's disease is a possibility, that's reportable, and the rest of the office need to be assessed because they would be at risk. Let's just have a look at the patterns of consolidation as they apply to different segments of the lung. So this is a fairly detailed map of the lung. However, what I want to highlight to you is that when a consolidation occurs, any structure that is adjacent to that consolidation, the border between that structure and the consolidation is blurred. What this amounts to is that, remember, the consolidation looks white. So what this amounts to is that middle lobe or lingular consolidations tend to lead to obliteration of the left or right heart border. Consolidation of the lung, the lower lobe of the lung, especially the basal segments, would lead to obliteration of some part of the diaphragm, whereas consolidation of the upper lobes tends to lead to obliteration of the mediastinal borders, the superior mediastinal borders. And of course, with upper lobe pneumonias, you see that nice straight line representing the horizontal fissure as well. A 56-year-old diabetic with sudden severe shortness of breath. Pause the video. Tell me what this X-ray shows and what you think is the likely cause. So this X-ray would be consistent with acute left ventricular failure with the typical bat swing appearance of the fluffy infiltrates, perihilar infiltrates, and actually also cephalization of the blood vessels. You can see these vertical lines here, which suggests cephalization of the blood vessels. This would be consistent with left ventricular failure secondary to a myocardial infarction. We've given some other reasons in the text as well. Here's a 63-year-old man with long-standing increasing shortness of breath. He presents with an acute exacerbation. Pause the video, see if you can have a guess at what this is. Some of you might have said this is also pulmonary edema, and I can't fault that. However, this sort of reticulonodular shadowing that is more homogeneous and more uniformly distributed, rather than the bat wing appearance, might suggest something different, like interstitial fibrosis, and the history doesn't really lend itself to a diagnosis of cardiac failure. Some causes of interstitial fibrosis, which include drugs like amiodarone, inflammatory diseases such as rheumatoid arthritis or even SLE, and also it can be seen in some chronic lung infections like tuberculosis as well. And finally, here's a 72-year-old smoker who presents with hemoptysis and pleuritic chest pain. Look closely at this X-ray. Look at the symmetry of the X-ray. Look behind the mediastinal border. Pause this video. Tell me if you can identify any abnormalities here. So I pointed you in some directions. This actually shows a left lower lobe collapse. You can see that there's a reduced size of the left lung and a double shadow behind the heart. So you see the double shadow there now. Let's go back. Now you see it. If you look at the ribs, you can see that the spaces between the ribs on the left side is much smaller than the right. So there's loss of volume of that left lung. And one other thing, look at where the heart border is. That's actually the lateral edge of the vertebral bodies. So the heart border is somewhere inside here. So the heart has been dragged towards the left because of the reduced volume of this lung as well. This would be consistent with an obstruction to the left main stem lower lobe, not main stem, the left lower lobe bronchus, leading to a collapse of the left lower lobe, reduced volume of the lung. So that was a little bit of application of the ABCD approach, and a little description of some common abnormalities you'll see. I would suggest you go back over this video, pause the video, apply the strict ABCD approach to describing each abnormality, and then describe the abnormality itself as thoroughly as you can. I found these two videos interesting and informative. Thanks for your time. Goodbye.